Hello, my name is Stacey Brown, and I am an associate professor and a program director in the Department of Public Health Sciences at the University of Connecticut. My poster presentation will describe a program I began in 2024 known as PHLAME, which stands for Public Health Learning in Action through Multidisciplinary Education. PHLAME is a student-informed, co-curricular model designed to strengthen public health workforce readiness in ways that directly support health disparities research and practice. The program is grounded in structural competency and anti-racist pedagogy, recognizing that health disparities are produced by systems, institutions, and power, and that the workforce itself is shaped by those same structures. As a reminder, health disparities are not only a product of unequal conditions in communities, but also of how the public health workforce is trained, supported, and sustained. Graduate students preparing for disparities-focused work are often navigating structural stressors themselves, including racism, financial uncertainty, caregiving responsibilities, and institutional cultures that privilege productivity over well-being. And these conditions disproportionately affect students from historically marginalized backgrounds and can limit who remains in the pipeline to do health equity work. PHLAME was developed in response to this reality. The program treats well-being, relational capacity, and critical reflection as structural interventions, not individual coping strategies. By supporting students' ability to remain engaged, connected, and resourced, PHLAME addresses disparities at the level of workforce preparation and retention. PHLAME was designed through structured student listening. Across the academic year, we conducted facilitated listening sessions with graduate students. A rapid thematic analysis identified priority areas including mental health support, career clarity, relational communication, and mentoring needs. Students were positioned as co-creators of the program involved in every aspect of its development. To date, PHLAME has engaged more than 150 graduate students through a series of workshops that have involved trainings such as QPR, Question, Persuade, Refer, Suicide Prevention Training, and Narcan training to recognize and respond to opioid overdose signs, career readiness workshops focusing on how to leverage social media sites like LinkedIn, resume and CV writing, and informational interviewing preparation, wellness sessions such as Reiki and meditation, advocacy sessions including testimony writing and knowing one's rights. Evaluation data demonstrate that participants had increased confidence in navigating career pathways and greater comfort engaging in relational communication across differences and stronger help-seeking behaviors. Qualitative feedback highlights clear professional identity formation and an increased sense of belonging. These outcomes matter because workforce attrition and isolation are themselves contributors to disparities in who conducts, leads, and sustains health equity work. Building on these findings, PHLAME is collaborating with other organizations to launch a bi-directional mentoring model beginning in March 2026. This model will address disparities in access to social capital, professional networks, and institutional knowledge. Rather than a hierarchical structure, we will model reciprocal mentoring, recognizing that students, early career professionals, and seasoned practitioners each bring critical expertise shaped by their positionality. By disrupting traditional mentoring norms, this model aims to reduce isolation, strengthen retention and equity-focused fields, and build leadership capacity across career stages. In this way, mentoring becomes a mechanism of addressing disparities within the public health workforce itself. In closing, PHLAME demonstrates how student-informed, structurally grounded, and anti-racist co-curricular design can support health disparities work by strengthening the people who actually do it. Ultimately, PHLAME matters for health disparities because who is trained, supported, and retained in the public health workforce directly shapes whose problems are studied, whose voices are centered, and whose communities benefit from public health action. Thank you.